Jonathan. So it's a pleasure to introduce Dr. Heather Cheng, who's an assistant professor at the University of Washington. She's a medical oncologist, really making some very insightful inroads into understanding genetic risk and predisposition. So Heather?
Thank you very much. It's a pleasure to be here today. I was here a couple years ago. I missed last year, so we've made actually quite a bit of progress in that interval period, so I hope I'll be able to share some of that excitement with you. Let's see if I can get my slides to advance. Okay, so just by way of introduction of where we're going to go today in the next few minutes, I'll first talk about, just remind you, prostate cancer is one of the most heritable cancers. So if you have a family member who has prostate cancer, if you have a father, if you have a brother, your risk of prostate cancer goes up. And that also means that for men who have prostate cancer, there may be implications for their children. Genetic risk factors for prostate cancer have been known for some time, such as BRCA2. Some of you may be familiar with that. I'm going to tell you a little bit more about that. And we now know more about how genes like BRCA2 and related genes affect prostate cancer biology. They also are suggesting some new, really exciting treatment opportunities for men in the more advanced setting, which is the other arena in which I practice, which is patients who have more advanced disease. So there's a lot of excitement there too. I'm not going to spend so much time talking about that because that's going to be covered in subsequent talks. But just to let you know, there's that connection as well. How can we use this information to help patients and their families? That's really important to me and a lot of our group's work. And what are we working on now and why? So what do we talk about when we're talking about genetics? Thank you to Raymond Carver. This is just to remind you or to also emphasize that when we talk about genetics, we're talking about a couple things. So it includes, and this is the emphasis of my talk today, is inherited genetics, which is also called germline genetics. And this is where any individual, each of us, have inherited from both their mothers and their fathers DNA, and these are the genes that make up who you are, and they are found in all cells of your body. They can be associated with higher risks of cancer. They are also called cancer risk genes or cancer predisposition genes. So these are genes that if you inherit them, increase your risk of cancer, but doesn't necessarily mean you'll definitely get cancer. These are genes like BRCA2. There are also cancer-specific genes, which are also called tumor-specific genes or somatic genes. We also will talk about those in many of the talks later today, but what that refers to in distinction to inherited genes are things that are private to the cancer. These are have arisen only in the cancer itself, and so picked up only in the cancer cells. They are not in all of the cells of your body. They are not in normal cells. They are only in cancers or potentially in precancers. They are not passed on to their children. They are not inherited from your parents, but they can be extremely helpful in planning for your treatment. And so that, I think, is important to keep in mind. What I'm talking about today and for the rest of this talk is really the inherited component. There's a wide overlap, but I just want to sort of emphasize how that's different. So 2 years ago in 2015 when I was here, I talked about BRCA2 and how it affects the risk of prostate cancer. Some of you may remember that talk if you were here. This is a family tree, or what we call a pedigree. Let's see if I can get a pointer here. I don't know if we can, oh yeah, good, you can see that. So this is a pedigree. This is an example of a family tree for a family that might have BRCA2. You can see up at the top there is a man in the family who was diagnosed with prostate cancer, and subsequently there were daughters that developed both breast and pancreatic cancer, as well as ovarian cancer and breast cancer. So these are the types of cancers that are involved in BRCA families. So again, they have inherited a risk of cancer, but they don't necessarily develop cancer, but the cancers that they develop include prostate cancer as well as pancreatic, breast, and ovarian. So we know from a number of studies that BRCA2 carriers, people who inherit BRCA mutations, have a 5 to 9-fold increased risk of prostate cancer. BRCA1 carriers we think is a little bit less, maybe about 3-fold increase. The importance of this is really in thinking about family history. So a lot of us are used to thinking about if you have a brother or father or grandfather with prostate cancer. But what I want to emphasize is that it's also important to think about the female side of the family. We should be thinking about sisters, mothers, aunts who have other types of cancers, and really, I think, just expanding your view of what's important. So first degree relatives are those brothers and sisters, mothers and fathers, people who are separated from you by one degree, and then grandparents, aunts, uncles, and cousins are second degree relatives. It's important to think about if they're coming all from the same side, or if they're from mother's side or father's side. These are things that I encourage you all to talk about with your own families, and also to share it with your doctors. So details, if they're available, about the cancer diagnosis. What kind of cancer did they have? Did they have more than one type of cancer? What was the age at which they were diagnosed? Somebody who has prostate cancer at 50 is very different from someone who has prostate cancer at 80. If you have any details about aggressiveness, that's important. Did the person in the family have Gleason 6, or did they have Gleason 10? So if you happen to know or are able to ask, that's useful information for your doctors. If the family member is no longer alive, did they die from their cancer, or how aggressive was that cancer? So I'm going to shift a little bit and talk about that some inherited genes confer a very high risk, and others confer a less high risk. So you may have also heard in the past about these other modifiers. So genetic, some components of risk are informed by both lifestyle and diet. We heard from Dr. Neuhauser as well as Dr. Wright, environmental changes as well as genes, and that's what I'll talk about here. I just also want to emphasize that of the genetic component, there are genes which you can inherit that are very common, meaning maybe half of the room might have them and the other half doesn't, but they may come with them just a very small change in your risk. So the risk, and I'll talk a little bit more about this in the next slide, and then there are more rare variants in the population, maybe only 5 to 10% in advanced prostate cancers, that actually, if you do inherit them, increase your risk quite a bit. I hope that'll become clear in the next slide. So this is another way of thinking about it. Genetic effects on cancer risk are not equal. So if we start off saying that the average lifetime risk of prostate cancer is somewhere in the order of 1 to 7 men, let's say you start here down at the bottom of this staircase, there are a number of studies, and many efforts have gone into these types of studies called genome-wide association studies. And those are studies which really have comprised a lot of the work in genetics in the past, and they are common genetic components in the population. Again, maybe half the room would have these, and they affect a small amount of risk. So you might just get a 1.5-fold increase in your risk, or a 1.5-fold decrease in your risk. So they're like small changes. Genes like BRCA2, on the other hand, are rare in the population, but they're going to increase your risk by 5 to 9-fold. So instead of getting a small incremental risk, and maybe you go up one step or half step up, a half step down, you add them all together. On the other hand, there's these genes which make a huge difference. They will actually take you to the next floor. Those are the genes we have learned much more about in the recent past. So BRCA2 mutation carriers, we also know with prostate cancer, have more aggressive disease. This is a slide I think I may have shown a couple of years ago. So on the left is overall survival. These two studies are from the UK, a group that basically has a wide number of families that they've studied. So of families and men who have BRCA mutations, this is survival. They do less well compared to men who don't have those genes, and the metastasis-free survival is also less favorable. So these do confer more aggressive features. And again, they substantially increase the risk of prostate cancer, potentially other cancers such as male breast cancer, pancreatic cancer. They do associate with more aggressive disease and worse outcomes in historic series. So I want to emphasize that too. However, in looking forward, by better understanding the biology of BRCA and related mutation in prostate cancer, we can begin to tailor our screening. We can begin to tailor early detection. This is sort of sort of along the lines of what Dr. Etzioni was talking about. The more we know about this, the better we can kind of look more carefully and tailor our approaches. We can design new strategies to improve chances of cure for men who do to get a diagnosis. And at present, we're already able to add highly effective precision treatments to the therapy toolbox for advanced disease. So these are drugs like PARP inhibitors and platinum chemotherapies that I won't spend as much time talking about except to say it's really exciting. You'll probably hear more about it later. And so together, all of these things will help us envision a dramatically improved outcome for people who have these mutations. And so the outlook is actually very favorable because we can understand the disease more precisely. So this is going to be, I think, similar to, for those of you who are familiar with diseases like chronic myelogenous leukemia or CML, patients, once we knew more about the mechanism, they are living much longer. And same with HER2 breast cancer. HER2 breast cancer used to be the worst breast cancer, but now since we understand we have targeted treatment, it's now a better form of breast cancer. So I think the same is going to be true for BRCA and related genes in prostate cancer. So in considering the family, we know, I'm going to talk about more in the slide, men with metastatic prostate cancer should be offered germline testing, and I'll tell you why in a second. We have a trial coming up very soon called the Gentleman Study where we'll have the opportunity to do that, so stay tuned about it. More cancer or somatic sequencing is also going to potentially identify men who have these mutations. More men identified for treatment purposes in the advanced state is also going to lead to more family members being identified through what we call cascade testing, or once we know somebody has a mutation, then we have the opportunity to test their brothers, their sons, and their other family members who may be at increased risk for both prostate but also other cancers. So prostate cancer screening guidelines, opportunities for improvement. This slide didn't get translated, but the point was really that it's clear as mud. And I think it's really to reflect the fact that, as Dr. Etzioni was saying, the USPSTF screening bodies have recommended against PSA screening. I think it's got lost in here. It's actually supposed to be superimposed. But the point was really that the screening guidelines, those early detection guidelines for people who are at increased risk, meaning they have a family member, they have a father who has prostate cancer, or they have a BRCA mutation, has really been lost in the current guidelines across the board. And at best they say, well, you can consider that in the discussion, but there really is quite a bit of confusion, and it is unfortunately at present clear as mud. But I hope that we'll be able to improve that in the near future. So this is a study from the UK called the Impact Study. They're trying to do this now. We're kind of midway through. We're really looking forward to results from this. This is an international study, men with ages 40 to 69 who are recruited from families that have known mutations. They get a yearly PSA, blood biomarkers, urine biomarkers, and they can biopsy, or they have a biopsy threshold of 3. The point is really to say that it looks like there is benefit for people who are at increased risk. So if you have a BRCA2 mutation, the likelihood of the early screening strategy is going to be probably more helpful. So this is what we're doing here. This is a study that is still in development, and I hope we'll be rolling it out soon in collaboration with Todd Morgan and also our own Dan Lin and Jonathan Wright. But this is a targeted early detection program in men at high genetic risk for prostate cancer. So these will incorporate more in a clinical trial fashion where we can collect the evidence that Dr. Etzioni needs of PSA yearly, of digital rectal exam, of using some of these really exciting new biomarkers from the blood and from the urine that you'll hear about more in subsequent talks. This is probably the biggest news, I think, in my small area of since the last time I talked. So this paper came out in the New England Journal of Medicine last year, 2016, really led by our group, by Dr. Pritchard, Dr. Nelson, and others. But this study, I think, is landmark. So this study is in men with metastatic disease, people with advanced disease, approximately 700 from 8 centers. In this study, we did not account for family history or age of diagnosis. That will be analyzed, but they weren't selected on that criteria. The study used next-generation sequencing to evaluate germline, or again, inherited mutations in 20 BRCA-related DNA repair genes. And the real exciting or dramatic finding, which was much, much higher than anyone previously thought, was that over 10% or almost 12% of men with advanced metastatic disease had inherited mutations in 16 DNA repair genes. So these, you can see the pie. The pie is really almost a little less than half of the pie is BRCA2, which I told you about. We know more about BRCA2. But the other parts of the pie, these thinner slices, we know much less. So genes that we're going to be learning about in the near future, ATM, CHEK2, BRCA1 we know a little bit about. PALB2 we don't know very much about at all. And so we're going to be learning about these in the future. And we're working on that now. So we know, again, about BRCA2, much less about these thinner pie slices, but that's work that we have to do together. To remind you about the schematic, I told you earlier about variants that can create small changes to your level of risk, and that BRCA increases the risk by quite a bit. What we don't know is for men whose sons inherit these new genes, ATM, CHEK2, we don't know where on this staircase those genes are. How many steps up does that mean? And so how can we use that information to guide their screening approaches so we can detect their cancers early? We don't know that yet, so we're going to be investigating that. And do those same mutations, I just use ATM as an example, increase the risk to the same degree? And do they have the same aggressive biology as BRCA? We don't know that either, so we have work to do. So in part as a consequence of these exciting new opportunities for learning about these new genes, we've launched the Prostate Cancer Genetics Clinic and Pathway, where patients can come to see medical oncology and talk about what genetics means for their treatment options, clinical trials, recommend next steps for their patient, for them and their families. They can see a genetic counselor if they haven't already seen one to talk about risk assessment, pre-test counseling, post-test follow-up, navigating insurance, which is also a moving target, guidance on discussing results with family members. Sometimes that can be sensitive and can bring up a lot of issues. And then also referral to urology to really participate in some of these exciting new screening opportunities and early detection opportunities where we can use some of these new biomarkers. So the take-home points today: genetic testing will be increasing both from a cancer tumor standpoint, but also the inherited tumor, genetic testing. We're actively trying to maximize the benefit to not just patients, but their family members. A complete family history, including all cancers, mother's and father's side of the family, is necessary, but it's not sufficient. Prostate cancer screening should be informed by family history of cancers and increasingly our awareness of genetic risk. We're still learning a lot. We have a lot of work to do together about how newer genes affect risk for carriers. Research and clinical trial opportunities for men with BRCA mutations and related mutations are ongoing, really exciting. And we have the genetics clinic and prevention pathway that are resources for you and your families. Lots of people to thank. And here's information if you want more about it. I'll take questions at the panel.